Good evening, everybody. We are here with Nothing Pink and Carolina Breast Friends, and we have Rachel Murray, a nurse practitioner with Atrium Women's Health, here to do a presentation on women's sexual wellness.
All right, so I'm going to share my screen. Rachel was teaching me how to be savvy with technology earlier. Okay. And then, perfect. Okay, can everyone see?
Yep.
All right, awesome. I'm really excited. This just seems like a really intimate group. I'm so happy to be here with everyone, and it's really nice to talk with all of you and hopefully get to learn some more stories. Arnell, I really appreciate you sharing your story, and I hope that tonight will shed light on how we can make this more positive. Okay, I'm trying to figure. Okay, there we go. So anyway, I think we are doing a great job of catching breast cancer more often. I think we're doing a great job of coming up with treatment plans that are appropriate for women and investing and really have a lot of passionate specialists around the country who are looking at research in how to make these treatments more effective, how to make them less difficult for women, but that doesn't change where we are right now, right? Which is that treatments for breast cancer, treatments for women who may be more susceptible to breast cancer are really affecting quality of life. And just the diagnosis alone is affecting quality of life. And I'm not sure that we're consistently having those conversations with our patients, and that we hope will change. So sexual medicine is the focus specifically on intimacy, and that can have a huge impact when we're talking about just a diagnosis or going through some of these treatments. And so our goal in the context of cancer is really to change the conversation around breast cancer so that women can leave our office and our treatments feeling more powerful, and maybe even recognizing that life can be maybe not vibrant, possibly, but certainly better with this diagnosis and some of the care that we can give. So who are we? Our title is Atrium Health, Women's Health, Sexual Health. And we focus specifically on sexual medicine. So what is sexual medicine? We work with women who have decreased libido. So these are women who have less desire for intimacy. And if you are a woman who has less desire for intimacy and this is not affecting you, it's not distressing to you, then I'm not concerned. There's nothing physiologically wrong with your body for not wanting intimacy. But if it is distressing, then that's affecting your quality of life. And there are certainly things that we can do about it. We work with women who have decreased arousal. And when we talk about arousal, we're talking about vaginal lubrication. So becoming lubricated in response to erotic cues, our nipples becoming erect, becoming the clitoris becoming erect. And we also work with women who have pain with sex, and this can look different depending on the woman. So pain can be pain in the pelvic muscles, which typically presents as a dull or achy pain, but it can be sharp pain. Pain most often is associated with the tissue. And we hear often that from women that it's a sharp pain, a tearing pain. The vagina feels like it's ripping open during intimacy. There cannot be any penetration at all. It's typically at the vaginal opening, but also can be with deep penetrative intimacy and intercourse as well. We do hormone replacement therapy. And I know that sounds like a scary word in the context of cancer, but there are situations for women who have breast cancer, survivors of breast cancer, or those who may have a genetic mutation that makes them more susceptible to breast cancer, where we do feel safe about using hormone replacement therapy. I do want to be clear, we are always going to talk with every single patient about the risks and the benefits, and we're not going to do any treatment without consulting with your oncologist and making sure that you feel comfortable with it. We work with inability to orgasm, so women who have blunted orgasm or just are not able to climax if they've never been able to climax or they can't climax anymore. And we also work with a condition called persistent genital arousal disorder. And these are women who find themselves being aroused at times when they don't want to be. It can be a really debilitating condition, and it typically does not show up in the cancer world, but it can. So I'm not going to speak about it as much tonight, but I did want to mention it because it's absolutely a possibility for some of you. And if it is happening, I certainly want to answer any questions and provide information about it. Our mission truly is to empower every single woman who comes into the door. That is our goal. So who are we? To the right, you will see Kalani and Melissa. Those are our nurses, and they are absolutely amazing. They are as passionate about this work as me and Dr. Davenport, who are on the left. And they just love to learn. They want every single individual that we see to feel strong and comfortable in the office, and they want to learn as much as possible every day. And on the left, you will see me and Dr. Davenport. I graduated from Vanderbilt University about 8 years ago, and was working mostly in private OBGYN practice out in California. And I went to my first ISWISH conference, so International Society for the Study of Women's Sexual Health, back in 2018. And I absolutely loved sexual medicine from that point on. This is a really detailed and specialized area of medicine that gets largely overlooked. I think that's part of my interest in it, is that there are so many women who just go to multiple specialists and feel like there's nothing that can be done, but there truly are treatments that can be effective, and we can change lives with this area of medicine. And also, I love the focus on just increasing quality of life and looking at hormones and different processes that could be happening for women, that are really affecting things. So I was trying to bring sexual medicine into my OBGYN practice where I was working, but I really wanted to focus on this work full time. And I started talking with Dr. Davenport a couple of years ago, and she went to school internationally. She went to medical school, did her residency in New York, and eventually landed in Charlotte, and has been working down here in OBGYN, and found that there was a huge gap in care here. And so she has started this practice, the sexual medicine practice, and has brought me on board to continue helping it grow. And I'm so excited to be here with her. And really, we just want to change the conversation in the Charlotte area and really everywhere, and talk about sexual wellness for women. So that is us. What to expect when you come into our office. So we do a thorough, comprehensive initial visit. So we're doing a 60-minute new patient appointment, which from a provider standpoint is really special for us. We typically get about 20 to 25 minutes with our new patients in a general OBGYN office. So to have that full 60 minutes is really nice. We want to learn about the women that we're seeing. We want to learn about your trauma. We want to learn about your quality of life. We want to learn what your diet is, what your alcohol intake is, what your relationship is like, what are the things that you've been through, what's contributing to any issues that you're having. We want to hear your story. And from there, we take what we call a biopsychosocial approach, which I'm going to speak more about in a bit. We do a thorough physical exam if we need to. And I tell every single woman who comes into the office, you are in control. So if you are not ready for an exam today, if at any point it's painful and it's just not the time to do it, we will take a stepwise approach to that. I don't want women to feel uncomfortable as a part of this exam. And then we do tailored treatment options. And what I'm really referencing here is that we feel that we're going into a partnership with every woman that we see. We are not here to tell you this is your diagnosis, this is your condition, and there's no conversation around it. I am very willing, and Dr. Davenport is very willing to look up any research that you may find that is different than what we're seeing, to answer any questions that you have. We truly just want to provide education, teach you what your options are, and then together come up with plans that we both feel safe doing. So again, this last part, it's the four of us in our office, and we are a really strong team, and it's a really special place to be. So all forms of cancer treatment have the potential to negatively impact some aspect of sex. So it can affect desire, can affect arousal, can affect libido, it can affect orgasm, and it can affect pain. The majority of previvors and cancer patients will have at least one aspect negatively impacted. And I did want to speak here about the word previvor. I learned this word from Rachel, and every single person on this call or who may watch this video later could possibly teach me the word. But I appreciate Rachel. I'm very grateful that she taught me this. And I think it's important as clinicians that we're speaking the same language as the women that we're working with. So in case you aren't aware, a previvor is someone who has a condition or mutation, most likely genetic mutation, that makes her more susceptible to certain types of cancer and may or may not have had risk-reducing surgery for this. So that is something that I really appreciate knowing going forward. And the last part of this is just to say that painful sex is the most common response that patients may have, and that's 45% or higher. And this can lead to a lot of other things. So many things in sexual medicine are cyclical. So if you have painful sex, you probably don't have libido and you're experiencing pain. Therefore, the vaginal tissue isn't becoming lubricated because your calming nervous system, your parasympathetic nervous system is not working as well. And we're really going to break all these complex concepts down more. But I'm just shedding light here on how much this truly can affect so many women who think they just need to live with these things, and they really don't. So cancer does not have to define you. And I have not had cancer myself, and I can't speak from that place. My mother was diagnosed last year with DCIS, and I was very close with her through that process. But I think the biggest thing that I would say is that you could have two ductal carcinoma in situ diagnoses or two metastatic breast cancer diagnoses, and two different women that handle that in completely different ways. And for one woman, she's able to have surgery and continue going on and living her life. Or maybe for a woman who's on chemo, she's really able to function well. And for some other individuals, it can be extraordinarily difficult. And there's nothing wrong with any of these responses that women can have. But we do hope that in some way we can help increase quality of life as women are going through this time, and educate women during what can be a truly difficult time. So the words you see on this page are just to shed light on all the different options that we have, and what we can do to treat. And I'm going to speak more to all of this later, but I just wanted to show you that. So funny story, Rachel sent me an email that she opened this at a soccer game, and it was actually like, I don't know, a fourth the size of this. And then I was like, why do I have the vestibule as a fourth the size of this slide? It has to be the whole slide. So this is the vestibule. This is my very favorite part of sexual medicine. It is amazing. I don't know if all of you can see the gray line here, but we're going to do some basic anatomy. I'm sure many of you are aware of this, but just as an FYI. So the white skin around, you'll see this is the mons pubis at the top with the hair, and then we go down and we see more white skin, and that's more of the labia majora. I don't know how to, I wish I had like a pointer. And then we have what we call the labia minora. And we have the vestibule, which is this gray area drawn out, which really goes from sort of the bottom of the clitoris to what we call the perineum down here at the very bottom. And this area is rich with estrogen and testosterone receptors, and we need both. And it's separate from systemic hormones that we need for other reasons. So we need estrogen in our bodies, right? But we also need to prevent hot flashes and to prevent bone loss. But we also really need it in the vestibule and in the vagina. And without it, it can cause significant tissue changes and pain for so many people. You will also see at the top the clitoral hood. So that is more of the skin area. And then the clitoris looks white here, but it should be pink. But what can happen for many women is that the hood, which is the skin, it does protect the clitoris. So it sits over the clitoris. And then what can happen with hormonal shifting is that the hood can stick to the clitoris, and that can lead to decreased sensation or pain, one or the other. blunted orgasms. So it can have a significant impact for many women, which we'll talk about more later. So, what is the impact of this diagnosis? And the point of this slide is really just to show that whether you are a previvor or you are a woman who has been diagnosed with cancer recently and is going through it currently, or if you are someone who is a survivor of cancer, the changes are really the same. So, body image changes. You don't have, obviously, if you have surgery, that can significantly impact the way a woman feels about her own body. I certainly have seen my mother go through this. But also you can just have a diagnosis of cancer, and that can change the entire experience that you feel on the day to day living in your own body. So we really want to be a safe space for women to come and talk about those changes. If you're feeling those changes, it's going to be really hard to experience intimacy in the same way that you maybe always have, right? Like maybe you're used to experiencing your body in a certain way during intimacy, and that completely changes. And depression, anxiety certainly can have an impact. This can lead to a lot of sad feelings for many women, and certainly a lot of anxiety going through multiple surgeries that we heard about earlier, and just thinking through like, okay, I just have to get through this one and then this one and then this one. It can certainly bring up a lot of fear for women. And of course, all of these things can lead to quality of life changes overall. Painful sex, we spoke about earlier, which we're going to get more into the nitty gritty on that. Inability to orgasm, decreased nipple sensation after a mastectomy or a lumpectomy. So we have erogenous zones throughout our entire body. And there are women who can orgasm from their feet. There are women who can orgasm from their nipples and don't need stimulation in the vestibule or the clitoris or the vagina. It's truly in other areas of the body. And if we're taking off the nipples and we're doing surgery on the breast tissue and we're taking out that nerve tissue, that can be extremely debilitating for a woman. Menopausal symptoms when we talk about our endocrine therapy. So tamoxifen, aromatase inhibitor, chemo prophylaxis, chemo prevention for women who have a genetic mutation, who have not been diagnosed with cancer, or tamoxifen, aromatase inhibitors, or those who are going through chemo and radiation can lead to menopausal symptoms, which we're going to get much deeper into. And then, of course, low libido. So let's talk about the different types of menopause. Menopause is 1 full year of no period, and then the period does not return. So the average age of menopause is 51 and a half. That's like the only detailed thing that I remembered from nursing school, and I'm really proud of that. 51 and a half, that's the average age. But it's 1 full year of no period. Women can start to space out over time, and eventually they just don't have a period. So you could have a period in May 2023 and then not have a period again until March 2024. You're not menopausal. But if you go from May 2023 all the way until June 2024, in theory, technically you're menopausal, right? And so that is menopause. Premature ovarian failure is no menses for a full year, no period for a full year prior to the age of 40. So this is basically when the ovaries are just done sooner. And it is possible, it's not likely, but it is possible that women who have premature ovarian failure could potentially have periods again down the line. Early menopause is just going into natural menopause between the ages of 40 and 45. Surgical menopause is removal of both ovaries prior to becoming naturally menopausal. So this is what we see often with our BRCA carriers, other genetic mutations that women may have, and there are a number of them. So surgical menopause is the most abrupt, and that is where you could be feeling great one day, and then the next day you all of a sudden are having hot flashes or night sweats or experiencing pain with sex. We heard earlier about changes to vision, which is certainly not textbook, but doesn't mean that that is not a real response that an individual has had. So just things to consider when we're talking about treatments. Of course, absolutely, we want to do the things that are going to keep women safe and prevent cancers, and then we also want to just raise awareness to the quality of life changes that can happen. And then iatrogenic menopause would be menopause from surgery, but also medications. So that's where we're talking about being on our tamoxifen, our aromatase inhibitor medications, the chemotherapy. And when we talk about iatrogenic menopause, that is, periods could potentially return after chemo. After surgical menopause, they're not going to return. So this is important because of the significant impact these things can have on quality of life. So chemotherapy may lead to sudden loss of ovarian function. Same with radiation. Tamoxifen is a selective estrogen receptor modulator. It's called a SERM. There are a number of these. And what they do is they have, they're friends of estrogen in certain tissues, and then they're not friends. They're kind of enemies with estrogen in other tissues. So actually, tamoxifen is an enemy of estrogen in the breast, and that's why what we want, right? So we're going on tamoxifen to prevent breast cancer from forming in the breast, and that is how it works. Some of you may know also it is a friend of estrogen in the uterus, so sometimes we want to watch for bleeding in the uterus, but that's just to give you an idea of it being what we call an agonist and an antagonist. So it's preventing anything from happening in the breast tissue, but it's causing things to happen in the uterus. Aromatase inhibitors, that's your anastrozole, exemestane, and letrozole. So these suppress estrogen levels in the blood by inhibiting an enzyme called aromatase. And what the goal is there is to take your estrogen levels down to zero so that they're just not there. And the idea is that breast cancer will not form, right? And what all of these treatments can do is greatly affect the vagina, the vestibule, and lead to hot flashes and night sweats and all of the things. So now we're talking about significant vaginal dryness that women experience. So you have your burning pain when a penis or a dildo or a vibrator is entering the vagina. It's a searing pain as that's going back and forth. Clitoral phimosis, which is what I spoke about here. So that flap of skin, the clitoral hood, is connecting to the clitoris, and we can only physically see some of the clitoris, but not all of the clitoris, or sometimes the entire thing is completely hidden from us. So women have that decreased sensation. That patient is going to come in and tell me, I don't feel as much. I don't feel anything. I used to be able to orgasm from clitoral stimulation, and all of a sudden I can't, or it just hurts. Women can have immature vaginal tissue. So when we don't have the estrogen and the testosterone in that area, the vaginal tissue becomes less mature. The tissue is more prone to infections, and women can be more prone to urinary tract infections. These are all associated with what we call genitourinary syndrome of menopause. It is the same exact mechanism. So GSM is associated with menopause. This is associated with the medications that you're on at this time of your life, but they essentially are doing the same thing. And then the pain. So an area of significant sensation for so many women is in that vestibular area. So where this little gray line is, and so when we are sucking up those estrogen and testosterone receptors in this area, we are causing women to have the tearing pain, the searing pain. It feels like my vagina is ripping open. I tried to have sex with my partner when it lasted for 2 minutes and then it stopped. That's what we're referencing. Women can have hot flashes, they can have night sweats, they can have changes to cognition, they can have fatigue, and weight gain. So, and a note on weight gain is hard. Weight gain in menopause, on average, women usually gain about 5 pounds. That is very much an average. It depends, and it's usually adipose, so fatty tissue around the lower abdomen. There's no trick to it. So some practitioners, I am not doing some of the weight loss medications. Certainly, people are doing them. But the other thing is nutrition. So I am a huge believer in seeing nutritionists. It doesn't mean that you don't know anything about nutrition at all. It's just that there are certain nutritionists that can help you maximize how feeling better in your body. So just something worth exploring. So let's talk about what are the things that we can do, because that's like really why we're all here, right? So this is a model of the biopsychosocial approach that we're taking. And there are 3 different ways that we think about sexual dysfunction generally. One is neurotransmitters. So we're talking about communicators in the brain. that are just not communicating as effectively. We have inhibitory neurotransmitters, and we have excitatory neurotransmitters. And there's no way that I can measure your neurotransmitters and say, well, we need to balance this one or this one. But it is something that we consider in the context of like certain medications that might be causing higher levels of certain inhibitory neurotransmitters. I will leave it at that. And then there's hormonal. So that's where we're talking about all the things that we're talking about, right? So the treatments that we have can significantly decrease the number of hormones that we have. And women can have the decrease in estrogen, which leads to the hot flashes and the night sweats. That's the systemic issues, but also the vulva, the vagina, the vestibule, all of those areas can be affected as well. And also women need testosterone. So we do not have testosterone levels as high as male testosterone levels, but we do need it. It does affect our libido, and not having it can certainly be an issue for some individuals. And then the most likely scenario when we're talking about female sexual dysfunction sort of is referencing what I talked about at first, but we're talking about inhibition versus excitation. So when we're talking about this, there have been studies done that look at women who have hypoactive sexual, I always say this wrong, hypoactive sexual desire disorder, HSDD. And the women who had HSDD, there were women who had HSDD and women who didn't that were put in a room to look at erotica. And the women who had HSDD did not respond. They did not have the same blood flow. They had decreased blood flow in their brain in response to erotica, as opposed to women who do not have HSDD. And the theory behind this is that women who have HSDD have a lot going on in their prefrontal cortex that is preventing them from being able to focus and hone in on their parasympathetic nervous system, so the calming nervous system, and they're activating constantly their sympathetic nervous system. So those thoughts could be anything from, I have to make breakfast for my kids in the morning, I've got to go to soccer practice, or I have metastatic breast cancer and I'm terrified of this treatment. It looks different for many women, but the point is that we want to balance our inhibition and the excitation, right? And the reason that this is important is because there are a number of things that I'm going to talk about that we can do that are simple and that just bring us back into the moment. And simply living, especially in the US, is going to really tap in on that fight or flight, that sympathetic nervous system, and prevent us from really wanting to partake or enjoy intimacy. But we want to think about ways we can sort of step back and step in. So what are the medications that we can do for low libido? We have a medication called Addyi and Vyleesi. These are both FDA approved for premenopausal women, though we do have some good data on it for postmenopausal women up to the age of 65. Addyi is a medication that you take nightly. It can make you fatigued, but you just take it before bed. We tell women not to drink more than, if you're going to have more than 2 glasses of wine, just hold the dose on it because it can lead to low blood pressure. But generally speaking, it can increase sexually satisfying events by 1 to 2 per month, which I know sounds low, but that's speaking to the full system. So that's speaking to ability to want, so having desire, becoming aroused, so becoming lubricated, having orgasm, and then also, I don't think it speaks to pain, but the whole system. And then it's indicated specifically for desire. And then Vyleesi is a medication that is an auto-injectable pen, like an EpiPen, that you inject 45 minutes prior to wanting intercourse. And it is effective for 24 hours. So women may want intercourse within 45 minutes, and they may want intercourse again 12 hours later, and that's completely fine. Buspar and Wellbutrin really speak to those excitatory and inhibitory pathways. So Buspar is an anxiety medication, and it's really just going to help keep things level. It's a good medication to give to a woman who might just be really diving into worst case scenarios with her diagnosis, right? And then Wellbutrin is a medication that is going to get a woman excited. So maybe a woman who is feeling relatively depressed over things, feeling totally unmotivated to participate in activity, but she wants to participate activity. So we could try Wellbutrin. The downside of Wellbutrin is that it can potentially increase anxiety. So we have to level that out and balance that out. So these are the natural things we have. So sensate focus, there's actually a good amount of data on this. This is getting naked with your partner and touching different areas of the body and noting temperature, noting sensation, and truly the idea is just connecting with your partner in a different way, decreasing maybe some of the anxiety around potentially body image issues that a woman is having, potentially trauma around a diagnosis or some of the treatments that we're doing. So this can be really effective way of just stepping back into the moment. The other thing that I hear often from women is that, they've participated in intimacy in the same way for years and years and years with the same partner or with different partners. And all of a sudden it's not working. And the question is, well, why is it not working? But sometimes doing something like sensate focus can really change the way that we're thinking about intimacy and make it more enjoyable. Sex therapy and cognitive behavioral therapy are similar in the sense that we're trying to change the way that we think about things. So we're tapping into anxieties, fears we have, experiences that we have, associations that we have with intimacy, and we're thinking about how can we look at that differently. These can be really effective ways to change the sexual experience that women are having. Sexual aids, so I'm referencing vibrators, and these can be good to add some excitement, which can be really important, but also increasing blood flow to the area. That's the other thing that the lack of estrogen does, is it decreases blood flow, which is part of what prevents the sensation. So we need to increase the blood flow and help with that. And then lifestyle, meditation, diet, and exercise. So for anorgasmia, we can do vaginal estrogen and testosterone. And I know that sounds scary. I'm going to speak more to why it's okay. I'm sure some of you are, or maybe all of you are aware of this, but I'm going to talk more about why the vaginal and estrogens and testosterones we generally feel okay about. To be clear, of course, we are always going to talk with your oncologist. We always want the women that we're working with to feel safe about any treatment plan that we have. And our mission is certainly not to just throw these medications at you and tell you to do them. So we certainly want to be in good dialogue with you. But it is the most effective. It is the most well studied in general, in terms of helping with some of the pain that can happen in the tissue. Also laser therapy. So there are different lasers. I'm sure many of you have heard of the Mona Lisa. That's what we did at my last office. Our new office is getting the Photona, which is really exciting. And these are, the Photona specifically is working by heating the tissue, and it's safer in the sense that it attracts water more easily. And so we're not having to use as much energy. The effects are generally good. The tricky thing about the lasers is that the effects are good, but they're not consistent. So we have studies that show that there's 75 to 85% improvement in vaginal pain and discomfort, or vulvar pain and discomfort, with doing a laser. It's just that they're expensive. It's about $3,000 for 3 treatments that you get 6 weeks apart. And if you do it and it's not effective, that's the downside. Lysis of clitoral adhesion. So that sounds like a scary word. I promise it's not a scary word. It's freeing the clitoris from the hood. So I've talked about how that skin covers the clitoris for some women as a result of hormonal changes most often. And so what we're doing is we're actually putting a really, really strong numbing medication on the clitoris, and we're peeling back on that tissue. We're not cutting. In some cases we will cut, but if we will tell a patient why, we will tell a woman why we're doing that and get her permission. But we're peeling back on the hood to help expose the clitoris. There's a fantastic sexual medicine physician out of Washington, D.C. Her name is Dr. Rachel Rubin, and she did a study on lysis of adhesions. I think she surveyed 61, I'm going to confuse it, but I think it's 61 patients with a 67% response, and anywhere from 70, I think it was somewhere between 65 and 75% improvement in ability to orgasm, pain, and arousal. So definitely can be beneficial for women. The downsides to this are it could not be beneficial. And also the hood could readhere to the clitoris. So we have women do maintenance estrogen or some sort of maintenance moisturizer to prevent it from readhesing, and just continue retracting the skin. So we'll have them pull back on the clitoral hood, which we can teach them in the office. Pelvic floor physical therapy for hypotonic muscles. And this probably isn't going to be related to your cancer treatments, but I do think it's important to mention because there are so many women walking around with this, and certainly the cancer treatments can take us over the edge to where we're not orgasming because of other things. But the pelvic floor muscles, most commonly in pregnancy, but this can happen for various reasons, can be not toned enough. And they're really important. Your pelvic floor is intricate, it is vast, it is sitting in the middle of your body. And when we are pregnant, it's holding up an entire baby. And so there are hormones during that time that relax, and the baby is pushing on those hormones. So the baby is pushing on those muscles. So the pelvic floor is not well supported, and then women can just have lack of tone. An orgasm is contraction of the muscles, and contraction of the uterus. And so if the muscles are not toned, it can prevent a woman from having a good orgasm. And we will send her to pelvic floor physical therapy. So these are women who are, or men who are trained in pelvic floor PT, meaning they're physical therapists, but also what we prefer is someone who has a special certification in women's health. The exam will be more similar to what we're doing in a gynecologic office. So there will be some external evaluation, but also will be some vaginal evaluation as well. And then sex therapy and cognitive behavioral therapy and lifestyle modifications. So painful sex, we call this dyspareunia in the medical world. We can do the vaginal estrogen and testosterone to help stimulate those receptors. We can do our vaginal laser. We can do non-hormonal suppositories and that's totally safe. So hyaluronic acid, our body makes hyaluronic acid. It can come in different forms, and it can be really, really effective. There is a study to show that it is as effective as the vaginal estrogen. There are not multiple studies. It's not 100% equal, but I've certainly had women have good results from that. So it could be worth trying. Pelvic floor physical therapy in the context of dyspareunia or painful sex is most likely because you're guarding, because you're in pain, and then the pelvic floor muscles become really tight because you are trying to tolerate. And so what we need to do is send you to a pelvic floor physical therapist to relax those muscles. And we have some good therapists that we work with. So let's talk about the hormonal and non-hormonal vaginal suppositories. We have DHEA. So this is, the brand name is called Intra Rosa. When DHEA first came out, it's dihydroepiandrosterone. This is an androgen. When it first came out, everyone said this is safe for breast cancer, women who have breast cancer. And in general, most oncologists and providers would still say this is totally safe. There's some newer data that says that it increases systemic levels of a hormone called estrone, which is a form of estrogen, but it is a weaker form of estrogen that's around after menopause. So there's some skepticism around that, but generally speaking, again, this is a conversation we would have with you and your oncologist to discuss. The next four, so Vagifem, Estrace, E-string, and Imvexxy. These are all forms of vaginal estrogen. Vaginal estrogen, when we are using it in a postmenopausal woman or in a breast cancer survivor or woman with breast cancer, it does not increase hormone levels in the body above that of a typical postmenopausal woman. So that level is typically about 5 picograms per milliliter. When you're premenopausal, your levels are anywhere from 40 to 400 picograms per milliliter. So it increases with estrase specifically, that has the most systemic absorption, but that it still is very low. It still is not at the premenopausal level, and it goes back to baseline. There have been some studies to show that it can increase and then goes back to baseline. Vagifem is the least amount of systemic absorption. So if oncologists, many oncologists will say they're most comfortable with the Vagifem, though there are certainly oncologists that are very fine with estrase as well. And then E-string and Imvexxy. Imvexxy is a vaginal suppository that comes in a 10 microgram and a 4 micrograms. So if a woman is not feeling as good about the 10, she can do 4. It may not be as effective for vaginal dryness, but we don't know unless we try. And then there's Reverie, which is the form of hyaluronic acid. There are a number of formulations of that. And Replens is over the counter. Replens doesn't have as good data behind it, but it certainly can be worth trying. Okay, so hormones for the high risk breast cancer patients. So this is important to consider for our BRCA1 and 2 women. And as far as I know, there's not much information out there about other mutations. But when we're talking about BRCA1 and 2, we're talking about taking the ovaries potentially in 30-year-olds and 35-year-old women, and certainly before menopause. And many of you are aware that that can lead certainly to the sudden surgical menopause, but also increased chances of cardiovascular disease and speeds up bone loss, right? So for all of us, when we go into menopause, we lose estrogen, and that is going to make us more susceptible to cardiovascular disease and make our increase our bone loss. And so we're doing that at an earlier age for our women who have BRCA1 and 2. So there are 2 meta-analyses, and what this means is just a compilation of number of studies that looked at women who had risk-reducing surgery and did not show any increased risk in breast cancer for women who did hormone replacement therapy who had risk-reducing BSO, so had their ovaries removed. This is obviously a case-by-case basis. Absolutely. It depends on the person. I think there is an exception for triple negative breast cancers. And it certainly is a conversation we would 100% have with an oncologist, and probably is already being had by the oncologist, but just something worth considering. And then the last slide I have for you here. So these are just medications that we can do for hot flashes that are non-hormonal. So there was a new really exciting medication that came out earlier this year called Veozah. This works on communicators in the brain, neurons in the brain, called the KNDy neurons. And those neurons are known to sort of swell looking for estrogen after a woman goes into menopause. And this medication is decreasing that swelling, hence decreasing any hot flashes that a woman may have. And then Brisdell is an FDA-approved medication. My computer just said something to me, but anyway, did I lose my slides? There we go. Brisdell is an FDA-approved medication, usually for depression, anxiety, but this is not even at that dose. It's a dose that's lower than the therapeutic dose for depression, anxiety, and it can work for hot flashes. And then there's a number of selective serotonin reuptake inhibitors and selective norepinephrine reuptake inhibitors that can potentially be effective. So I have listed here the potential efficacy rates. I just had a woman diagnosed with a genetic mutation the other day who is struggling with anxiety and depression, and then also having hot flashes. And so we're doing the desvenlaxofine to see if that is effective for her. And we'll trial that for about 2 months and then see how she's doing. And then the last 3, gabapentin, oxybutynin, and clonidine, these are medications that are indicated for other conditions, but if it's matching up. So like if you have overactive bladder and hot flashes, I might use oxybutynin for you. And then acupuncture actually there's some good data behind acupuncture and helping with hot flashes. So okay, that is all I have for you. And I'm happy to take any questions.
Wonderful. Thank you so much, Rachel. That was really informative. You gave us a lot to think about and reach out to you about. So thank you so much for being with us tonight.